Yeah, good morning, everyone. Welcome to another week of cardiology rounds, echocardiography rounds. Today we have a Halloween-themed presentation. It'll be presented by our chief cardiology resident, Dr. Noah Lewis. Noah, if you just want to take it away.
Sure thing, yeah. So I guess in the spirit of Halloween, discuss some images from the ASC that they had put out, I think, last year around this time. We'll try to make it as interactive as possible, and hopefully everybody can hear me all right here, and hopefully online as well. So today is just a little bit different. Let's see, there we go. So I chose just to put some cases together, kind of in the spirit of Halloween, of just some interesting findings as I just came off the ward, and touch base on a few of the concepts after going through the echoes and the cases. So it's a little bit of a mix of different things, but some peculiar pathology to walk through. No disclosures, and then I'll walk through the learning objectives as we kind of go along from case to case and summarize everything at the end. All right, so the first case, I'll give you just a quick summary, and then I think we have a few of the cardiology residents here just to walk through things. So the first case is a 67-year-old gentleman who presented to the emergency room following assault on public transportation, and he had a forehead lac, which was stitched by emerge. He was a bit tachycardic, so just routinely did an ECG in the ER. He had no known past medical history or home medications, and then just demographics. He unfortunately was from no fixed address, and originally from Ghana. This was his ECG, and I don't know if Chris or Jeffrey, just a quick run through. So normal, abnormal, and what's the quick pertinent finding?
Abnormal sinus with I guess left axis deviation, but abnormal finding the deep T wave inversions that the cortical lesions.
Yeah, exactly. So these deep T wave inversions. So they had urgently called cardiology to assess, and then the patient didn't have any symptoms whatsoever. Had no chest trauma from the assaults, and blood work was completely unremarkable. He had a normal chest X-ray, in fact, and so they actually ordered a more urgent echocardiogram directly to emerge, and everything should play automatically here. And I'll walk through a bunch of different images. So just personal long axis views with color Doppler and just 2D. Nothing crazy dramatic here, and I'll walk through things. And if anybody has any questions or things you want to discuss to point out as I go through these, please let me know. There's just some early short axis images. It turns out okay on the TV screen. It's a little bit better on my computer. And there's the mid LV, and there's closer to the apex. Actually, another view here is just right at the apex in the short axis. And then this is the closer to 4-chamber view. So, what do you think of this?
So looking at this, it looks kind of like spade size. I'm thinking of things that need HCM, but I'd love to see it on contrast ideally as well.
Anybody have any comments here?
What else? What else is that going on at the apex?
Pardon me. So there's also like a thrombus or something that's kind of coming in and out. I'm not sure if that's thrombus or not muscle.
Associated with a large apical aneurysm.
Oh. You see that echo density there, just at the tip of the ventricle that's getting bigger with systole. See that? Yeah. Right, that's getting bigger in systole when the rest of the ventricle is getting smaller, right?
Echo drops out.
Yeah, so I'm going to go through things and they put color across it. Any other thoughts? The same theme here.
See how the color shows to and fro? Sometimes if you can't see the angles, you see that color to and fro, you should really.
You're saying right here?
Yeah.
Yeah. And the other hint is that you'll see that two flow into the aneurysm in systole, but there'll be a diastolic flow that comes out after if you do CW. So it's a double Doppler sign. So
Yeah, unfortunately, they didn't really have good Doppler signals on I downloaded the images. Very focal, yeah, with a very narrow neck. What we're just seeing probably on the other images, like the board chamber, this might be just papillary so here or just.
see that blue flow that would be diastole.
Yeah, I think that bright flash of yellow is actually in diastole.
That's the early diastole. That's the forward flow after it starts to relax. So that's diastolic obstruction.
So the summary and report from the first case essentially reported as normal LV size with mildly reduced LV function, about 45%. You can go through all the images, but some regional wall motion abnormalities. They measured a 21 millimeter by 18 millimeter.
All of us are on going, they didn't use contrast.
No, they didn't. So this was, no, they did not. So there were no contrast images. I guess just to give you some backstory, this was initially, I think, seen around like 6 a.m. by the cardiology residents on call and picked up on bedside.
Oh, I see.
But then they got an echo around 8 a.m. This guy did not really speak English. You know what I mean? There was at least no chest trauma. That's what they were kind of worried about. And then based on the ECG, people were worried about was this maybe myocardial infarction with late presenting mechanical complication, but otherwise we kind of talked about all the pertinent findings here. There's a small adjacent pericardial effusion, but yes, they did not use contrast in the study, and there was really no significant valvular disease. So this was considered an LV aneurysm, and just to review briefly some pertinent points. So there's true aneurysm and false aneurysm, what we call pseudoaneurysm, related to the number of wall layers that are involved. In terms of differential, that we talked about apical HCM with aneurysm is the most likely diagnosis, which it was in this case. But there are other things just to consider and think about. Generally, there are possibilities to having a true aneurysm, but these are usually large, broad-based, they're very strong and fibrous, and there's usually no LV thrombus associated with these. The most common that we get concerned about and see are the patients that come in with acute myocardial infarction, anterior wall MI, and they have this mechanical complication where they have either a large pseudoaneurysm develop, and we also see that with those ECG changes and on the clinical story. And this guy didn't have a troponin rise, he didn't have anything else to say that he had any history of any MI, although he would maybe have had risk factors just based on his age and demographic. Trauma, as I discussed before, based on this gentleman coming in with the assault on the TTC, and then other things like infections or vasculitides and Chagas disease that we don't really see typically here in Toronto, but they are possibilities to keep on the differential, as well as some medications and postpartum as well, but very rare. When it comes to apical HCM, there's some pertinent points. It's an uncommon variant, about 8% generally, more prevalent actually in East Asia, of up to 25%, compared to areas in Africa where this gentleman was from. Rarely do we have that subaortic LVOT obstruction that we're most worried about with Holcomb, but we did see, as we discussed, some of the mid-cavitary obstruction that these patients can develop. About 25% may develop atrial fibrillation. Most of them have no symptoms or mild symptoms. In this case, this gentleman never had any symptoms whatsoever. We saw that this ECG had those giant negative T waves in those apical-related leads. And then, as Jeffrey had discussed, the spade-like sign that we see that's typical of an LV cavity and diastole on imaging. They can see an echo, MRI, or on CT. These patients do have a lower risk of sudden cardiac death, but we use the same criteria for primary prevention ICD to determine whether or not they would benefit from those therapies. Just to show you a little bit more of a prominent example of a patient with apical HCM and their ECG. And then it should play as well. And this is a contrast image, at least, not for this patient, but trying to show the typical findings of more of the spade-like sign in apical HCM.
And remember to look for the spade in diastole.
I think the ECG is put out here.
Overcall it if you see a spade. It's so
Definitely. So is this diastole?
Yeah.
The other thing about these apical HCMs is it really highlights the need to actually find the true apex, what the apical four-chamber view, which can be challenging. We frequently foreshorten the apex.
And actually, the first couple images that they saw, like the peristernal long axis, you didn't see it. And the first couple apicals, they didn't see it either. So they went a little bit lower, and then you saw this big.
No, we have some cases here where the first echo didn't show it, and the second echo showed it just because you got better views of the apex. So, and contrast has been shown to be able to better define the true apex.
So the
The thing is, remember the apex is actually thinner than the rest of the ventricles, so the criteria for HCM 13, 15.
Yeah, there are times on echo we'll describe the lack of tapering at the apex as maybe an early sign of vivid HCM. So I feel a bit sensitive.
Right. Okay. And then just a pertinent point, more clinically relevant for us, is the fact that when we look at the aneurysm size, in this case, it was greater than the 2 centimeters. This should alert for potential consideration for prophylactic anticoagulation in primary prevention ICD. This paper was with actually Dr. Adler, and he was the consultants working with this patient. So he had discussions in terms of primary prevention ICD. Unfortunately, this gentleman did decline it, but they are at higher risk of sudden cardiac death in the context of these larger aneurysms that we do see, although overall lower compared to the patients with other variants of HCM.
Tom and Dr. Parker and Dr. Chow will tell you there were a lot of sessions on HCM at the Cardiovascular Congress. So you hear about all these aspects.
Exactly.
Thanks to our sponsors, the mouse isn't. Like there's actually news. Like some years we have amyloidosis, that predominate the whole session, and then some years like this year's actually HCM.
This year was
Say something about apically displaced function.
Yeah, I think we just didn't visualize it well on the.
It's one of the important differential diagnosis. The prognosis of such patients are much better than true patients with HCM. We have similar findings when patients show up to our office. They have the very abnormal ECG, and then in the echocardiogram, you often see the lack of space in the apex. But doesn't typically have the diastolic space shaped. It becomes difficult sometimes to look like it's really important for our sonographer colleagues to actually help us to show the whole course of the papillary muscle. So, having a sweep in the papillary muscle, you have an important suspicion of it. We're trying to make the differential diagnosis. So again, we need our sonographer to help us to think, what we're looking for. And also echo contrast will be helpful. Typically, we make the diagnosis on the MRI. So I do follow a bunch of patients with it. The initial description of it was actually from a whole bunch of Korean papers that describe these phenomena.
I'd like to use the first class classification of the podcast. Exact contrast from the hierarchy how and take that how it enters into the LP classified.
I see. That's a good point.
I'll take a video of it as it passes through. That will be actually very helpful. So,
No.
3 suites.
There's something Dr. Parker's kind of thoughts on this, but I guess certainly as Dr. Chow mentioned, is the apically displaced path muscle can certainly be somewhat of a mimicker of apical HCM. But I thought I'd read that they could actually have both together.
Yeah, that confusion. It can be isolated or they can be together. And remember, if you do genetics on all comers with hypertrophy, you'll probably pick up about 30% of the positive results. So in the cases of isolated apical displacement, it's worth at least doing genetic testing for sure.
That's a good point. Well, thanks for the discussion, everyone. I won't belabor this point just to get to the other echo cases, just in terms of clinically for us, in terms of risk factors for sudden cardiac death and HCM, and the criteria that we use for consideration by primary prevention ICD. In this context, actually, this patient actually got a cardiac CT urgently, like right after his echo. I think they had initial concerns of making sure that this wasn't infarct related and a complication. They also wanted in terms of the thrombus. This is just one slice picture that I had taken for this patient. It was a true aneurysm. There was some fatty menoplasia with a layered thrombus, so we started on anticoagulation. I had very similar measurements to what we had described on the initial echo that was non-contrast, and then he had normal coronary artery, normal coronaries and normal origin of the coronaries as well.
I think this is a nice example how like we talk about aneurysms versus pseudoaneurysms.
Exactly.
Pseudoaneurysms usually are the ones with the narrow necks and the but whereas this has a quite a narrow
No
neck.
neck, exactly. That was the concern.
It involves all the layers, obviously, right? And so it's
And that was kind of the concern that they had. They couldn't really get a good history from this guy, and they just wanted to make sure.
And some patients with apical disease, apical hypertrophy without aneurysm, have chest pain.
Right.
And if you do nuclear studies on them, they'll have apical ischemia, and a predictable percentage will go on to develop this as essentially a new.
Right. That's a good point. So just to summarize, in terms of just clinically, this patient was started on beta block anticoagulation, decline in ICD, some social disposition, kind of planning things that changed his care. All right, moving on to the second case. So this was an 84-year-old lady. She presented as a code STEMI with several hours of chest, neck, and shoulder pain. This was on the background of several days of GI illness, some past medical history of depression, in which she was on medications such as bupropion, deslamp, vaccine. She had a history of thyroid nodules and hypothyroidism on levothyroxine, and remote colon cancer with hemicolectomy, adjuvant chemo. But she had a normal echo a couple years ago and no previous cardiac history whatsoever. This was her ECG here, and basically they had some concerns initially as there was some dynamic ST changes in her anterior leads associated with her chest discomfort. You can see also the high lateral leads as well. Was concerning, so she was urgently brought to the cath lab. She had a troponin rise. She had an elevated NT-proBNP at admission. They did a cath and only showed mild to moderate coronary disease. At maximally, it was just some 40% lesions in her CA and LAD with no culprit. And then the patient did get an LV-gram at the time as well, an EDP of 28 with severe LV dysfunction. We'll get to the actual good images on the echo. This is your 2D images for the peristernal long axis, and then just the base of the heart short axis. I'm not sure if anything jumps at anyone on the left image. So try to maybe hint to something. These are continuation of the short axis 2D images. You can see good function at the base, and then as we go into the mid, down to the distal segments, significantly hypokinetic regional variability, and then there's also something in that LV there. And this is down to the apex.
Yeah, it looks like consistent with the stress very mild.
Yeah, and then anything, Chris, like so there's a big LV thrombus. They did not use contrast. So there's just zoomed in images of the apex.
It's pretty well seen.
Yeah, it's pretty obvious. Yeah, and extends quite high up. So the summary of this echo case, again, normal LV size or severe LV dysfunction. EF was less than 40%. We saw those basal segments contracting the best. Then there was a large LV thrombus measuring just over 3 centimeters long, about a centimeter wide, with a number of mobile fragments. They didn't use contrast here, but it was very obviously seen even just on that first peristernal long axis. And then there was moderate TR, for what it's worth. The patient's findings with this was stress cardiomyopathy, particularly in the cath. Patient didn't have any stroke symptoms despite having an LV ram and a catheter in the LV at the time. Just to quickly summarize Takotsubo cardiomyopathy or stress cardiomyopathy, where the name is derived initially from that from the Japanese in terms of just the octopus trap, and that we have the basal segments contracting best with the apical ballooning, which is a traditional type of Takotsubo. I'm not going to get into the other variants necessarily here. In the context of this, there's a number of different risk factors. We don't really know the pathophysiology completely that may trigger in these patients, primarily in postmenopausal women. In this context of this patient, she was on a number of antidepressants that were also norepinephrine uptake inhibitors. She had an underlying GI illness that preceded this and had some depression and some social concerns at home that kind of initially brought on these symptoms. it presents often with these ACS or STEMI-like pictures. That's a good point there. I'll get to that. She did have a cardiac MRI, but it's a low percentage of cases, but we do see it quite commonly in the hospital here, given the number of presentations for ACS. LV function usually improves within 10 days, but the complication rate for these patients in hospital is actually similar to that of acute coronary syndrome, up to 19% for in-hospital related complications, whether it be heart failure or arrhythmia, or other severe complications, with mortality about 4 to 9% in 30 days. In terms of basic therapy, we know the ACE inhibitors have the most efficacy for these, and depending on the degree of LV dysfunction, we may use guideline-directed medical therapy for LV dysfunction. But in terms of LV thrombus and tachypseudocardiomyopathy, it's a little bit more rare. That only really happens, at least what I could find, was about 1, maybe 1.5% of cases. So it is quite rare for this patient to have an LV thrombus with a diagnosis of Takotsubo or stress cardiomyopathy. But it is possible. The prevention of LV thrombus for patients just with stress cardiomyopathy, there's very poor data suggests prevention if there's no thrombus. And a lot of that data is just extracted from patients with acute MI. It's reasonable in certain patients that they anticoagulate for 10 days, but that's not in any guideline. The treatment for LV thrombus in the case of this patient, again, is all data driven, again, from post-acute MI patients who develop LV thrombus. It's usually they use the same warfarin, vitamin K antagonists, and for a minimum of 3 months of therapy, and usually up to 6 months. The important thing to know from an echo perspective are the risk factors for thromboembolization that we think of. Most of this information comes from old studies before thrombolytics, because a lot of patients had thrombus, and then they monitor these patients basically with serial echoes and clinical studies, and they try to determine who was at risk of having a stroke, essentially, or some kind of thromboembolic event. Generally speaking, it's patients who are older, with larger thrombus burdens. At least the length of the thrombus is more important than the size necessarily, of about over 2 centimeters. The severity of the LV dilatation, LV systolic dysfunction, and then if there's any pendulous aspects or independent mobility, which this patient did have for both. Another consideration that's not discussed here, and again, this is maybe more pertinent to Takotsubo, is where these patients' LV function usually improves quite quickly, and when it improves, that might trigger events that could cause embolization. Just in terms of following up for this patient, she did have a cardiac MRI, was consistent again with stress cardiomyopathy. There was some hesitancy in terms of discharging this patient initially until the patient first was initially managed for LV dysfunction, but also given the size of the thrombus and the concerns for embolism. And so the patient was initially on heparin and enoxaparin, slowly changed to warfarin with a thrombosis service in clinic. And didn't have complete resolution. I didn't get into the details, but up to 20% of patients with Takotsubo may not have recovery in their LV function. She might, maybe in 6 weeks and plus, but there's a possibility that they might not completely go back to normal. All right, case number 3. So this is an elderly gentleman. He's 92. He had a routine outpatient echocardiogram and is ordered by his community cardiologist. He's basically followed for a bioprosthetic APR. It was a Hancock 2 valve for aortic stenosis. And coincidentally, he reported, at least to the ecotech at the time, that he had some increasing shortness of breath. And what was the trigger for stress? It wasn't actually clear necessarily. There's oftentimes I don't necessarily find the exact cause. In this case, the person was on medication, had a history of depression that might have triggered things as well as an underlying GI illness, so it wasn't related. But in terms of this case here, this gentleman was treated for cellulitis by his GP recently, and kind of complained as he was getting his echo done. He had a lot of swelling, peripheral edema with his caregiver that was with him, and he has a known ICD, AFib, and some underlying risk factors like CKD. Here's his echo images here. That's so odd. Yeah. And these are all cases I had last week. This is on the ward. These are all ward cases last week.
Wow. It shows you the acuity and the variety of the.
Yeah, so this is all within 5 days. Yeah. Yeah, so it wasn't hard to pick these cases. It was yeah.
Oh boy.
All right, so we saw that the bioprosthetic valve, we call it rocking. There's dehiscence, and there's severe paravalvular leak. There's some aortic dilatation as well. These are some short axis images here. And this is an outpatient echo. Gradients are pretty normal and everything's pretty normal like a year ago. I think there was like some mild paravalvular leak. Anybody else have any thoughts or try to get a variety of pictures here? There was at least moderate to severe MR as well. They had a very difficult time just based on the orientation of trying to get a proper Doppler signal across the valve, but I think from the color Doppler signal we could see. And then they tried again, it was just very off axis trying to get flow across the aorta to show the severity of the AI. You can see there's some trailing. This patient was also volume overloaded with severe TR.
Device as well.
Yeah. So this gentleman, to summarize, he had moderate LV and RV dilatation and mildly reduced dysfunction. So he had the Hancock 2 aortic bioprosthetic aortic valve was rocking severe paravalvular leak. Gradients again just off axis. Moderate to severe MR, severe TR with elevated RVSP, and there was some mild aortic dilatation. There was no obvious abscess or dilatation that was seen on there. Unfortunately, I was trying to download the TE images, but the computer kept freezing, so I wasn't able to, unfortunately, get acquisition for those. But there was no vegetation or abscess or anything like that found. Is very consistent with the transthoracic echo. Now, the pertinent points for this case was just related to the Hancock 2 bioprosthetic valve. Oftentimes, we don't get to see what the actual valves look like, or the details, at least in my training. So it's a porcine-based valve. It's used in the aortic valve position, the mitral valve position. It's very commonly used. It's known as, it's very durable. It's kind of a gold standard of bioprosthetic valve for a lot of patients. Now, in terms of just focusing on this patient's age group, because most of the data, again, is younger patients getting SAVR, that traditionally it's quite durable, and that for patients over the age of 65, again, a lot of these states are a little bit older, but it's kind of like a very low risk of degeneration in most patients at 20 years out. Which has surprised me. It's much, much lower, down to 68%, and the patients are like 50 to 65. I think a lot of this, again, was from studies where the patients didn't live longer than that. They kind of, most of them lived 20 years and died from other causes.
Now, was there any paravalvular leak at all in previous studies?
There was like mild. Yeah.
It's kind of unusual.
Unusual, yeah.
Very.
Yeah.
And I don't
Without infection.
Without, yeah. So at least that was known. Again,
And his cultures at the time grow anything?
As an inpatient, no. Yeah. So it's just, he just had some shortness of breath, a lot of peripheral edema, slowly slowing down. That his family knows for the last couple of months. There was no history of any infectious symptoms or B symptoms.
Got treated for the cellulitis, but
Yeah, which I think was probably just peripheral edema.
okay.
It was like a telephone consult with his family doctor. He was hypothyroid, so they replaced it. They started on levothyroxine.
Yeah, the dehiscence is not. It's not structural valve degeneration, right? Like it's not. It's
No,
not
so it's like,
different.
and he didn't really have elevated gradients even across the valve. So it was,
Do you consider that in the same bucket?
Well, I guess in the absence of infection, if you think it's just, which you're right, you wouldn't be usually think about calcification of the cusps and or regurgitation as structural deterioration.
Yeah, so this is in the case not necessarily of the classic degenerative aortic, surgical aortic valves or bioprosthetic aortic valves that we traditionally see where they have aortic stenosis. In this case, this is bioprosthetic valve dehiscence. It's very rare, apparently. It's only less than 1%. And this is especially with this very late onset of over 2 years since it was put in. It was put in 2009. The rocking motion really suggests that there's a large dehiscence in the aortic position of greater than 40%. So that's a lot of circumferential dehiscence. This is associated, again, as we saw, with severe paravalvular leak. There was some mention in terms of trying to do the severity of the paravalvular leak related to the width of the vena contracta. And it can also suggest how much dehiscence there is. The risk factors for this is usually prior endocarditis, particularly when there's an infection of the annulus itself, when there's a ascending aortic root aneurysm that's enlarging. So it again enlarges the annulus. There's severe calcification, particularly of the annulus rather than just the valve leaflets. And then there's degenerative regurgitation or vasculitis that can also cause this. This wasn't necessary for this patient, but this is more related to usually what we see in terms of looking at prosthetic valves and their the flow across and the gradients. For us, usually to know for mostly on the TAVI patients and so forth, in terms of like the severity, although in this case it's the opposite of this. So in terms of follow-up for this gentleman, for this patient, he was managed for his IV diuretics. He was worked up for endocarditis. There was no vegetation, abscess, or anything identified. He underwent TE, right and left heart cath. He underwent CT scans. He was worked out for TAVI, but he was deemed not a procedural candidate, and he went to the home for palliative care. Although when he went home, he was like ambulating around the ward, felt fine, so had no symptoms whatsoever. So obviously managed with diuretics until something catastrophic happens. Anybody have any questions there?
You must imagine TAVI will be very difficult to do in this case because your problem is actually the adhesive
Exactly.
brain.
Exactly.
So if you do something about valve, it will be still rocking.
Exactly. Yeah. Exactly. So yeah, he was worked out from surgical and yeah. Yeah. No. Exactly.
Fix the paravalvular.
Was the original pathology bicuspid valve?
No, because it was aortic. It was just trileaflet aortic stenosis.
Oh, okay, all right.
It was 92. He was like in his late 70s when he got this procedure.
Right.
But before
Okay.
this was before TAVI was offered in Canada. It was just before. It was like 2 years before. Yeah. All right, case 4. We're doing okay for time. This is a 76-year-old lady with progressive dyspnea. She has impedal swelling, abdominal distension. She was followed in the community for AFib, HFpEF. She had peripheral arterial disease, previous stenting, scoliosis, and ulcerative colitis, but was pretty stable, independent at home. She also had a history of a pacemaker with kind of an unusual pacemaker history. She's left-handed, had sick sinus syndrome with history of syncope. So she got a right-sided dual-chamber device. Lead failure about 5 to 10 years after that. Ended up with a replacement on the left side, with leaving in the right-sided leads. And then she's kind of followed from, we call it progressive valvular disease, not to ruin the fun in this. Yeah. All right, so here's your personal long axis, the first picture. And then we'll look at the RV and flow.
So RV is significantly dilated. There's a pretending of a tricuspid lead with a pacemaker lead into very much.
Yeah.
So lots of TR.
You can see the causation shadow actually.
Well, so much so you actually don't see the TR.
Yeah, no, exactly. Exactly. Yeah. I'm sure you can go 4 chambers.
We see this like twice a week here.
Yeah, I was gonna say, yeah.
Except the leaflet.
So it's
Packed down.
yeah, so like basically complete laminar flow, but open tricuspid valve orifice.
This is one of the situations where color flow mapping by Doppler may not work for tricuspid regurgitation.
Exactly.
So much of it.
Exactly. And then this is like showing hepatic flow reversal. It's the best image that blew up. Let me get big enough. So summary, as we saw, torrential TR, secondary to pacemaker, lead impingement, and actually leaflet perforation that was followed and it's known and it's been progressive. Had wide open tricuspid valve orifice with laminar TR flow, and then the systolic flow reversal of hepatic veins, and this mild to moderate other valve disease. And severely dilated RV, as we noted, with severely reduced function. This is her chest X-ray. So you can see maybe why there was issues related to the tricuspid valve over time. There was noted to be moderate to severe TR secondary to the first pacemaker implantation, and so they already had. She already is aware of the risk when they had the second one put in that it's going to get into bed. You'll see. I'll get to this in a minute. There's something else also here. So just to get into, with cardiac implant devices and the tricuspid valve. Okay. It's 5% increase. So basically, for the number of pacemakers and ICDs that go into the U.S., so in the hundreds of thousands, we're seeing that there's about a 5% increase in moderate to severe TR after 1 year of implant. For this number of devices put in, it's a very large number of patients. Besides that, about 80% of people have some form of TR, even if it's just tracer or mild. So there's a large population with this. We know this very well here at St. Mike's. Damage to the tricuspid valve, of course, may occur during the implant itself from direct trauma, whether it be perforation, impingement on the leads, or the leaf apparatus or the port A. But then it can also happen chronically over time as both the leads kind of fibrose and become in place, but also with the change when it comes to RV pacing, as it changes the RV architecture, causes RV dilatation, as we saw in this patient, and then leaflet tethering, which can lead to worsening TR. I won't go into the details here because I know we've had previous tricuspid talks, but just for like Jeffrey, Chris, and such, that is the anatomy for the tricuspid valve and where that can cause impingement or perforation. Looking at those short axis views, and we can see this on a number of studies that everybody here does the scanning and reading for the interventional procedures. And then there's variation within the anatomy itself as well. When it comes to grading, we call this torrential TR, and talked about how the Doppler itself, because of the laminar flow, is not necessarily, just visually might not tell us, and some people could miss that. So we have the actual kind of quantitative metrics that we can use. And then we know this here in terms of interventions when it comes to certain things with the clips that we're starting to use now. Of course, there's surgery when it comes to ring annuloplasty or replacement. And then we're starting to do a bit more of the TTVR type procedures here that we're familiar with. And then there's just the variety of valves. Some of these that we've used here at St. Mike's. This patient is in fact referred here. So we'll be seen soon for a transesophageal echo and CT for tricuspid valve intervention. So really the reason why on that chest x-ray, why you saw, I'll go back to it, there's a leadless pacemaker micro device here. This patient kind of is an outpatient being prepared for TTVR. And so they had implanted the RV lead, and that's all the way to the RV septum. So you can just see the size of the RV just on chest x-ray. And then I have a follow-up after laser lead extraction. They removed 3 of the leads, and they left in the 1 atrial lead so that there's AV synchrony. Because the new micro, it uses basically tricuspid valve closure, so not perfect in this case. And I don't know how it's going to work when I have a TTVR, but uses it for AV synchrony. Yeah.
So just a message to some of the colleagues. I think these days of age, not only you have to document or figure out how much TR there is, but also the mechanism. So it's very important to do all your sweeps in the peristernal, views, as well as the apical views, to try to figure out which leaflet is doing what, because I think that's really important to figure out the mechanism, because that's how it will guide us what we look for in TEs, as well as our course of treatment for our patients. So those are the new situation. It used to be we just ignore the right side, and then when we focus on the left side on the mitral valve in terms of mechanism, why it was leaking. Now it's the right side that we have to do that as well. So I think it requires thinking when you're actually scanning.
That's a good point. Okay.
It's very helpful.
So Bean suggests that we should use the 3D probe for the online audience. Well, why would we use the 3D probe? How do we use it?
So if you're using a 3D probe, nowadays we have lots of comes with the 3D probe. You don't have to keep switching and standard probe. 3D probe.
I see,
So
okay.
we're using that virus world.
You mentioned explain too.
Okay, got it. So the message to the audience is if you have a 3D probe, you can actually use like flipping different views as well as using the X-plane to look at the mechanism or the, I guess, morphology of the tricuspid valve.
And no, I assume because the leads had been in there for some time, the leaflets were disrupted, kind of tacked down for a while. One was perforated. With lead extraction, did the TR improve at all, or not?
No, so it was already, ventral TR,
Yeah.
it was anterior leaflet perforation,
And so,
and then the septal leaflet was also completely tethered.
I think beyond
So
that,
unrestricted.
beyond that, even you can see there was such a huge coaptation gap.
Exactly.
Right? There's an element of functional TR and
Exactly.
annular dilatation that won't change at all if you're moving that.
And so the initial worry was that in some of these patients, when the laser lead extraction, that they get into bad RV failure or heart failure because you can disrupt the tricuspid valve as you come out. But in this case, it's so wide open that nothing changed. So you just came back and forth.
what we're seeing with the TTVR is that you can have like paravalvular regurgitation is an issue,
Yeah.
particularly around where the pacemaker leads are. And that's like another tip for the sonographers is like if you see a pacemaker lead with a TTVR, really hunt and scan around it, because if you're going to find paravalvular regurgitation, it's probably going to be around there. And so I think it makes sense, especially with a patient having two leads going through the tricuspid valve annulus, the motivated removing the leads, putting the leadless in, and then you put the TTVR, that reduces the risk of having significant paravalvular regurgitation.
Yeah.
That's one of the considerations I think we're starting to learn with these valves.
Absolutely. So you'll find out more of the anatomy for this particular patient will be transferred here soon. Yeah.
Look forward to it.
Any other comments? On to case number 5. All right, so this is a 26-year-old male. He had a known bicuspid aortic valve. He had a remote balloon valvulotomy for severe aortic stenosis when he was a teenager, had 6 kids. He basically had a presentation to a community hospital with subacute fevers, GI symptoms, fatigue. Going through his nose, he was subsequently diagnosed with strep anginosus bacteremia. He was treated with ceftriaxone for several weeks. He had a number of imaging studies, one that showed septic emboli to his head. There was a small lesion on his aortic valve. He was on several weeks of antibiotics with the PICC line, and he was actually the day before they were going to send him home when he started to develop a lot of chest pain. And he didn't really know what was caused initially, and so he was transferred to a tertiary center, and he had this echo done. His initial echo was done about 8 weeks before this. So peristernal lung axis, you can see that there's a large mass on his aortic valve. Zoom into it and get some color flow. Anything bother you with that color flow? Too much. And also just in terms of, it's not just also going back into the LVOT.
Is there VST
as well?
Yeah. Is there VST?
Well, that's the concern. Or actually, no, because it's a little bit of, let's say, north of that. So concerns from the aorta. Yeah. So it's just a still image in terms of measurements, so quite large, over 1.3 centimeters.
Which echo system is this?
This is actually, so this is one of the old Philips machines. This is overnight on call. One of the cardiology residents did this full study.
Oh, wow.
Yeah, they did a really good job.
Pictures, yeah. Very good.
It is, yeah.
Is this the little laptop one they have in the CCU?
Yeah.
Oh, that's awesome. Okay. I like that machine.
The mind rate of that.
And so you see that there's some over here as well. These are short axis images. Early function looks good. These are short axis at the level of the base of the aortic valve. This is the 5-chamber. You can see that there's that mass shooting back into the AT. And again, this patient's not in any heart failure, this is chest pain at this point. I've been on some antibiotics already. This is that the little notch looking down the aorta. Yeah, yeah. So pretty profound. So this is and then formally read afterwards. The bicuspid aortic valve, large mass on the cusp of bicuspid, with the delay of the posterior cusp as well. There was severe flowing AI, and there was also elevated gradients as well. There was communication of the right sinus of Valsalva was a concern with the anterior space, especially for a ruptured sinus versus an abscess. And then again, really preserved LV function. And there was nothing really seen on the mitral valve or the tricuspid valve from the other images on the study. I also was able to download the TE for this one. And this is an intraoperative TE. So from anesthesia. So again, we see that mass on the aortic valve, bicuspid, the domain, that posterior split, and the color flow is very concerning.
Is it prolapse? Like what's so kind of interesting morphology even in diastole.
Yeah.
Leaflets, right?
Yeah, there is something funny about that during that. It's more redundant.
With bicuspid. You really see the masses a lot with that one.
Yeah. So the concern was also the sinotubular junction, the sinotubule, and the sinus of Valsalva, that there was the concern was here, and I don't have all the images, but basically there's a contained rupture, not just abscess, the abscess with contained rupture of the sinus of Valsalva, so the aortic root. So it was contained at least, otherwise it would be catastrophic. So there was hematoma in the mediastinum that had clotted. Yeah. So this chest pain was from basically dissection or rupture. Sure. Complete rupture, basically, not dissection, rupture.
Yeah, the roots, right?
Yeah.
Central rupture of sinus of Valsalva can actually lead to chest pain.
Exactly. Yeah. And this is basically, again, intraop, so as you see that there's now a mechanical valve, and there's a mechanical ventile performed to a pretty good result. Unfortunately, there was no cardiac CTs, but there was just a general CT that was done at the time. It's hard maybe to see from these types of windows. It's the best I could get from a chest window. But essentially here, you have your mass with contained rupture, and there's actually hematoma here. I don't think it plays well on the TV here. There's hematoma, abscess, and contained rupture here. So when it comes to bicuspid valve and infective endocarditis, patients with bicuspid aortic valve compared to the general population are about 12-fold increased risk of developing endocarditis compared to the general population. The lifetime risk is about 2 to 5% for these patients, and 48 per 10,000, which again is much higher, about 4 per 10,000 in the general population. This is also very concerning, particularly in bicuspid valve for children who develop endocarditis. It's usually that becomes a concern. 60% of patients who develop AI in the context of bicuspid aortic valve is usually related to endocarditis. Usually they present with stenosis. And then the higher rates of these paravalvular abscess that we saw in this patient, again, it's a bicuspid compared to patients with normal tightly fit aortic valves. A lot of these patients require cardiac surgery, just like this patient did. And then just overarching clinically for us, bicuspid aortic valve is not an indication for antibiotic prophylaxis in and of itself.
Was it? Did you guys used to treat prophylaxis patients?
Yeah, it's like mitral valve. Not an indication.
Yeah.
2007 was the cutoff date.
Yeah.
Like,
And you guys all stopped for BAPS.
All stopped.
Yeah, we used to do that in clinical.
Yeah.
And then just to keep this for time and focus just on echo, there's a number of imaging modalities that we do to look at bicuspid aortic valves, but also when we look at patients with bicuspid aortic valves, We're looking at both the anatomy of the valve itself and how we can describe it, both in the raphe, the orientation, the size, and we always don't forget about looking for aortopathy or coarctation in these patients and how that can be related to different signals. When it comes to aortic disease, and some of this patient, he had abscess that caused a contained rupture, but we just think about aortic disease in these patients when it comes to a common association with both the risk of dissection and the risk of just aortopathy or coarc, which is much higher in these patients than a tricuspid aortic valve, with a lifetime risk that really is also really just dependent if it's syndromic, if it's hereditary, and the rate of growth and size. And so we just always factor that in, so we can't just give clear-cut numbers based on the risk. But it really does just depend on size, like we do for any other type of aortopathy. Indications for surgery based on the thoracic guidelines that we know for exams, and then this is just an easier way to remember for people when it comes to studying most of my cohort or more junior trainees. In this case, this patient had life-threatening contained rupture, he had abscess, he had a number of reasons why he needed urgent surgery. And he was actually went urgently to OR, and that's why the transesophageal echo was basic. And then why the initial transthoracic was done basically on call, and then the TE was done in the OR because it was a pretty quick, once it was diagnosed, and the patient had already been on antibiotics for a period of time. It was brought urgently to the OR and actually did very well, was discharged home without really any complications. So just to summarize, I think I'm just reaching the hour mark. It's those 5 cases that I saw last week. In terms of looking at both apical HCM and in terms of differentiating true and false aneurysms and the differential diagnosis from this. Patients with tachycerebral cardiomyopathy in terms of diagnosis, but also the rare instance of LV thrombus and how to manage those patients. When we had a patient with a bioprosthetic aortic valve and long-term degeneration, or in this case dehiscence, the risk factors for that and understanding severe paravalvular AI. And then we saw that they had some pacemaker device-related complications chronically in patients to their tricuspid valve, the torrential TR, how to be able to measure that. And then what are the possible therapeutics interventions that we particularly do here at St. Mike's that this patient will be referred to. And then bicuspid aortic valve and the association with endocarditis, chest pain when it comes to abscess and root rupture and the relationship between that and aortic disease. So if anybody has any questions, I'm happy to. Thanks for all the discussion throughout. I was hoping for that. So thank you, and thanks for everybody's time.